How's it going, everyone? Welcome back to the Rehab Science Podcast. I'm your host, Dr. Tom Walters. Today we have a Q&A episode. I put a story up on Instagram and asked people to submit questions, and we got a lot of good questions there. I'm excited to test this type of podcast out. I hope it's helpful to all of you, and if it's something you like, we might do these on a frequent basis. Just again, ask you for questions and try to answer questions that are specific to things you might have going on, whether it's a pain issue, an injury, or just a health-related question that you have a question about. And if it's within kind of my knowledge set as a physical therapist and someone with a kind of exercise physiology and exercise science background, we'll answer in these episodes. So I'm joined with my awesome producer, Ben Hyatt. So Ben's gonna be a part of these conversations, and so we'll just be basically taking those questions and answering them, and hope this is helpful to you guys. So Ben, welcome to the podcast. Well, you've been in the podcast for a long time. It's just we don't see you.
I've seen a lot of podcasts, and I think we've done 16-ish episodes so far. Yeah, recorded, not all released yet.
Yes.
And so this is interesting to be on this side of things. So we'll see how I do monitoring the cameras at the same time.
Yeah, you've got your heads in a lot of places.
Yeah. So this is kind of cool for me because I always after the shows I'm always asking you questions.
Yep.
Right? Because we'll say I'm 50, and I have not been as active as I should be, kind of thing. So I just always have some questions because I'm starting to get more active again and stuff like that. So I think if you're okay with it, we'll go through these questions and then I'll kind of jump in with a couple of my own.
Perfect.
Throughout.
Yeah, that's awesome.
That
yeah.
Okay?
No, you always have great questions. We always talk about, when you're in something all the time, you kind of lose sight a little bit of what maybe the person who doesn't have a particular, it's like anything in life, right? Like, so a lot of times you have great questions because whether I'm talking to Kirsten or, an orthopedic surgeon or something like that.
Yeah.
Sometimes you can, if you're in that field, you kind of you forget what the average person doesn't know,
Totally.
Who's not in that field. So I think, those questions at the end, you always...
It's like for me, I am not a PT, so I am the perfect person because I really know nothing about this world. But it's like if I go to my dentist, the dentist tells me what's going on and stuff like that. And then I make him explain a little more because for him, it's just really simple.
Yep.
But for me, I want to know exactly what's going on, and they just have so much knowledge. So when I watch these episodes with you, and you've had so many great guests too, I mean, I'm just learning so much stuff. So I'm just becoming this wealth of knowledge.
Yep. No, it's awesome. Even for the people we bring in that are guests that I'm in there sort of closely in a movement field, I still learn so much. That's what's so fun about a podcast. I mean, those interview kind of things where you can learn so much from people.
Totally.
Yeah.
And this is, we're both people who watch podcasts too. So for me, I don't even watch TV anymore. I just watch podcasts and YouTube, and, hopefully I'm learning the right stuff.
Yeah, totally. Exactly. That's the tricky part.
Okay. So should we get started?
Yeah,
now?
let's do it. Yeah.
Okay. So I think what I'll do is I'll say who asked the question as long as I can pronounce it properly and the question. So the first one is from Kona Coffee _Sunshine. If they're in Hawaii.
Yeah, exactly.
So the question is, he's asking for exercise to help with high hamstring tendon pain.
Yeah. Okay. So this is high hamstring tendon pain. The technical term for it is proximal hamstring tendinopathy. Proximal just means that it's closer to your trunk. So high hamstring tendon pain would be, if you think about your hamstring muscles, there's really 3 hamstring muscles. They all come together into one tendon up towards on that proximal end near your buttock. So those 3 hamstring muscles will come up, they'll all blend together into one tendon, and then that tendon will hook on your ischial which is, it's like your sit bone. That's what I refer to as your sit bone. So if you were to feel the bottom of your pelvis where you're sitting, your hamstring tendon attaches right there. So people, when they get hamstring tendon pain, will either get it up there in their buttock region, or they can get it down behind their knee where those 3 hamstring muscles run down, and down there's 3 different tendons. So with high hamstring tendon pain, that proximal hamstring tendinopathy, you would approach it like we do other tendinopathies, where if we look at the research, the best evidence is on gradually putting load on the tendon. So, which essentially just means, I think sometimes people, they might hear that, what does putting load on your tendon mean? It basically just, it's like you're doing strengthening exercises, but you're gradually increasing the stress on the tendon. And so, and then if you look at the upper hamstring tendon, there are certain things that aggravate it. So we know that tendon, if it's compressed against the bone, and this happens to a lot of tendons in the body, if it's kind of pushed against the bone, it will aggravate it more. So people who have upper hamstring tendon pain, one of the things that aggravates them the most is sitting for prolonged periods, because you're literally on your sit bone, kind of squishing that tendon into the bone, and whether that's reducing blood flow or the exact mechanism there, it can really aggravate the tendon. The same is true if the person's hip goes into too much flexion. So flexion is like if you bring your knee up to your chest. When your hip goes into deeper degrees of hip flexion, it also compresses that upper hamstring tendon against the bone, which can happen in certain exercises. So like if somebody did deep squats or deep lunges, it can actually worsen that type of pain. Also, like just bent over. A lot of people, sometimes it's called yoga butt. Okay. Because in yoga, when people are doing hamstring stretches, that will also aggravate it, and that's when they'll feel the pain. So what we do is we're looking at gradually strengthening and loading the tendon, but what we'll do in the early phases is make sure people don't go into too much hip flexion. Okay. So they would do exercises where they just essentially aren't bending their hip too deep. So you wouldn't do deadlifts in the beginning of hamstring tendon pain rehab, because when you bend over into a deadlift, your hip bends, and that essentially puts the hamstring muscles on stretch and kind of compresses that tendon on the bone. You wouldn't do any exercises like that, like deep squats, deep lunges. Sometimes we'll do there's these hip thrust exercises where you're working the glutes and hamstrings. Those also take the hip deep into flexion, so you wouldn't do that in the beginning. Right. So a lot of the exercises early on, some of the best ones are actually just like hamstring curls. Like, have you ever seen the machine in the gym where you lay on your stomach? Yeah, and you try to bend your knee? That one's great, because if you imagine, you're laying in a way that you're almost laying flat on your stomach, so your hip is in neutral. Right. So it prevents the hip from being in those deeper degrees of flexion. Whereas there's another hamstring machine where you're seated. Do you know that one? Yeah, where you go. You sit and your legs out. That one wouldn't be a good choice, because you're in a seated position, so you're putting pressure on the tendon. Okay. And your hamstrings stretched. When you do it like the starting position, your knees straight and your hamstrings on stretch. Right. So that one is not great early in rehab, but would come later on when you're challenging it more. Building it up. Yeah. Yep. So you start with stuff that's kind of like less stressful early on. So like the prone hamstring curl, that machine is a great option. Sometimes people you can do hamstring curls like on a ball. Like you could lay and you lay on your back and put your heels up on a ball, and you do a bridge, and then you curl the ball in. Okay. And so which is hard. Yeah, it's hard. Oh yeah. On the ball, it's pretty challenging. So that's essentially what you're looking at. And there's actually a good article. I could put a link for that down in the show notes. There's a research article that has, almost kind of an infographic that shows what a sample rehab progression would look like for upper hamstring tendon pain. So I'll include that link so people can see what it would look like to gradually put more load on the tendon, but also think about starting with hip closer to neutral and then gradually putting it into more hip flexion.
So, okay, and I think you mentioned it, right, is people are aggravating this from sitting too much? Yeah. Is that mostly?
That's most of what it is. It is really hard to manage for some people because their jobs require them to be seated, right? So, or they drive a lot. Right. So I've had a lot of people that have long commutes, and it's really hard for them to permanently get rid of this issue. It just takes way longer because they're always aggravating it with prolonged sitting. Right. So that is, if you are able, behavior modification is such a big part of physical therapy. It's like trying to identify the things that aggravate it in life and then modify those or temporarily eliminate. So if you're at a job where you could get like a stand-up desk, or just take breaks from sitting frequently, that will help the tendon heal.
So the next question is from Alfredom24. He wants to know, can PT be completed with a patellar tendon tear, or would one need to fully heal first to begin?
Yeah, this is a great one. So the patellar tendon is on the front of your knee. It's you think about, you've got your quadricep muscles on the front of your thigh. They run down and hook into your patellar tendon, and then that tendon hooks. Tendons hook our muscles to our bones, so it hooks on the front of the knee. And if people who have patellar tendon tears or pain, usually it's kind of right below their kneecap on the front of the knee there. And this is a question that comes up pretty often, where when people have certain types of injuries, maybe injuries that sound or potentially are more severe, like a patellar tendon tear is, there's ranges of it. It could be just a small partial tear. It can be a complete rupture, right? Like there can be all levels. And if you have a complete rupture, you'd have surgery in most cases, a reconstructive surgery, and the surgeon would reattach it. With a partial tear, in many cases, you don't have to have reconstructive surgery. But I think sometimes people will think about those types of injuries and they'll think, oh, I shouldn't put any stress on this. I need to just kind of rest it and let it heal.
Right.
So I think this is a great question, because we really do want to get people with an injury like that, a tendon tear, we really do want to get people into rehab, pretty much immediately, once the maybe really acute kind of pain has calmed down. Like they might have a few days of rest but then they would be starting just some, gradual mobility exercises. And with a tendon, it's that same kind of thing we were talking about with the hamstring tendon pain issue. You would be looking at just starting really, really easy and respecting the person's pain and symptoms, but starting to put some stress on the tendon, because that really can help desensitize it and help it heal and recover.
Right.
You want the tendon to become strong again and improve its capacity. Right. And the problem with rest is, although like the healing process is going to go on, the tendon is just going to become deconditioned and weak. And then when you do go to put stress on it again, you're more likely to injure it or have pain, flare up again. So I think if somebody has an injury like a tendon tear, whether maybe it's a partial rotator cuff tendon tear, maybe it is that patellar tendon tear, maybe it's a partial Achilles tendon tear, you really do want to find a practitioner who can help you start putting together a program that puts just very small kind of easy steps on that tendon to kind of start building its strength back up again.
Right. So did you talk about on one of the other episodes too, if you don't start pushing it early on kind of thing, you'll never kind of get back to where you were kind of does that apply to this?
Yeah, it makes it harder. When it comes to that, if you're looking at mobility, there's certain injuries where people are more likely to lose joint mobility, and those can be really hard to get back. A tendon tear wouldn't fall so much that usually people people won't usually lose joint mobility with tendon tears. They may temporarily for a little while. Like if somebody with a tendon tear, if you had them ask them to bend their knee all the way, they might not want to because it would hurt, because it stretches the tendon to put some stress on it.
Okay.
But it's not like if you sedated them, you'd be able to bend their joint all the way. It wouldn't be stiff.
Yeah.
Whereas like if someone had a fracture, that kind of thing, especially if they have a fracture inside the joint capsule, like near the joint, then they can really lose joint mobility, and you have to work on that early on so that they don't lose it permanently. The nice thing about strength, I always tell people that if you've had an injury that compromises your mobility and strength, you really want to start with the mobility, because that, you can run the risk, like I was talking about, of having a contracture or losing mobility. But strength, you can pretty much always gain back.
Right.
It just takes longer. If the person... There are situations where people can't work strength. Like reconstructive surgeries are a good example. So if you've had a patellar tendon reconstructive surgery or like a rotator cuff reconstruction, there is a period of time where you can't really do much strengthening.
Right.
Because it's just too much stress for the healing area. The surgeon sewed it back together, and you just can't put much load on it. So, that is necessary for it to heal, but it also means that the tissue will get weak, which is fine. It just means it's going to take a little longer to get the strength back again. But I think this is a great question, because I think the thing for me when I, in thinking about this question is just that you really want people to, you've got to find the right practitioner, right? Like you've got to find a good evidence-based practitioner, but there's a lot to be said for getting rehab going early on after almost any type of surgery or injury. And it might be, there's something usually that you can start doing that's going to be helpful to your system, whether it's kind of a low load mobility exercise, or it's a really sometimes even from a strengthening standpoint, we'll just have people start doing isometrics. So those are those kind of contractions where you're squeezing your muscle, but you're not moving.
Right.
And maybe you're only doing it at 20 or 30% of your maximum force. So you're not squeezing hard, but just that little bit of stress helps the tissue start adapting and getting stronger.
Cool.
So, yeah.
Okay. That was a good question. Okay. So next question. Maddie Effick, as a recent graduate, he wants to know if there's any advice with helping with confidence as a practitioner.
Yeah, such a common thing to experience when you first graduate. I remember coming out of physical therapy school, anything you're brand new to, right? And you're going to start working with people who expect that you're going to have a knowledge around that area and be competent in the area and help them get better. And so it does feel like a lot of pressure when you first graduate. It's like you finish up your academic work. Maybe you had clinical affiliations where you're kind of working under a PT, and you kind of learn the ropes a little bit, but it's not like you have your own like dedicated kind of full caseload. So as soon as you start and you get your license, that is kind of a scary thing. It's like all of a sudden you have a job, and the next day there are patients on your schedule, and they're coming in expecting that you know what you're doing.
Right.
And so I think for me, when I was a new grad, one of the things that was the most helpful was I think you want to try and find a clinic, whatever job you start in, to have some people around you where there's kind of a mentorship piece to it. And even some clinics, actually, some of the clinicians will even get together for like an hour, maybe after work, certain days in the week, and just practice techniques or talk through things.
Right.
So I think if you can find a clinic that's really values the education component and building up new clinicians, in that interview process, that's something to look for. Like, look for a job that has that built in so that it's helping you grow and become a better clinician. The other thing that was really powerful to me, which is more common in the US now, I'm not sure in other countries if this is happening so much, but you can do residencies after physical therapy school, residencies and fellowships, sort of like doctors would, like medical doctors.
You did a residency.
Yeah, it was so amazing that I did an orthopedic manual physical therapy residency. So it was all orthopedic injuries, like we're always talking about.
Yeah,
and it had a focus on exercise, but even more of a focus on kind of that hands-on manual therapy. So different soft tissue kind of massage techniques and joint mobilizations and manipulations, and I felt like that jumped me ahead so much because you kind of come out of physical therapy school sort of like a generalist.
Right.
It's like you're learning pediatrics and geriatrics and orthopedics and neurological type care. And you kind of come out knowing a little bit about lots of things. And then you do some internships, and that kind of helps you become maybe a little more specialized. Say you do all orthopedic internships.
Right.
But if you can come out and do a residency, it's basically a year-long program in the U.S., and you only see those patients. And you have a clinical instructor who's kind of watching you and critiquing what you do. So that's the biggest things to me, I think, in terms of getting ahead. Like, try to find a job. If you can't, maybe a residency or fellowship isn't an option. If you can't do one of those, then try to find a job where there's older kind of clinicians who are willing to kind of mentor you and help you grow.
Right. Great. Another good question. That's why these are so good. So got another one from KNR 1104. So has notoriously tight glutes, painful in the morning. Any advice on how to loosen them up, what they should do?
Yeah, glute tightness. This is an area here a lot of people complain about, and often tie it into the low back as well. Do you ever get this?
I do.
Glute tightness?
Sure.
Yeah. Does it come from anything that you, or just out of the blue?
Well, I'm wondering if it does come from sitting and stuff like that, because I do sit a lot.
You do
during the day and stuff like that. Would it come from that?
Yeah, you do see people. I think just when you're static, both with low back and hip joint, when somebody's in a static seated position for long periods, you'll hear more. You'll hear more reports of discomfort in those regions. So, and I will notice I get a lot of glute tightness if it more so than any other muscle group, if I do a lot of leg type exercises, like if I've had a day at the gym where I do a lot of squats and
hiking and stuff too.
Hiking, yeah. If you have a lot of uphill hiking,
because
that's actually one of the best exercises for gluteus maximus is a tall step up. They call it. So you just take like one of those tall exercise boxes and step up onto it. But that one really works gluteus maximus, and I'll get for the next few days, I'll have I'll get that delayed onset muscle soreness in my glutes. And what I what it feels like to me is just glute tightness, and even my back will ache a little bit. And I find that there are some different stretches out there that are really good for the glutes. And I think for someone who's waking up, it sounds like they were having it in the morning.
Yeah, in the morning.
I mean, I think there are some stretches you could do just right in bed before you get up.
Right.
And so this applies to lots of regions in the body. But if you have an area that's kind of prone to tightness, say it's the glutes, there's some of the stretches that work the best are these kind of knee to opposite shoulder stretches. So if you're lying on your back, you would just basically, if I'm stretching my right hip, I'd pull that knee up and pull it towards my left shoulder.
Okay.
Feel a stretch in your glute. Another one that's used a lot is the figure 4 stretch, which is, again, if you're lying on your back in bed, you'd bend both knees so your feet are on the bed, and then cross one leg over the other, like just sitting with your legs crossed. And it's called the figure 4. And then you just reach down and pull you kind of pull your legs up towards your chest.
That's a good stretch.
Yeah. It even works good like seated. When you're talking about like people who sit a lot, I notice if I'm feeling sore in my glutes and I'm in a seated position, I'll do like I am now. I'll just sit with my leg crossed and then lean forward.
Right.
And you get that
you
stretch.
can actually feel it.
Oh, yeah. That one's such a good one. It's kind of like, and people have probably seen, there's the pigeon stretch. Have you seen that one?
I don't think, well, I might have, but I don't know.
It's a common yoga one. It's like the same kind of position where your legs crossed, you put it out on the ground like that, and your other leg actually goes back straight.
Okay.
And you kind of sink down on it. It stretches your glutes. But
the deep stretches for sure.
Yep. So I think those, usually for most people, those really make a difference. Those different glute stretches. Sometimes, if someone has maybe if there's an element of pain kind of radiating down there or a really severe tightness, I will, in a lot of cases, want to explore their low back, because the nerves that go to your glutes come from your lower lumbar spine, particularly from the L4 and L5 nerve roots.
Okay.
So, there are some people sometimes where maybe there's a nerve root kind of irritation at those levels, and maybe that's the origin of their glute tightness. So they could keep stretching their glutes and until you address their low back. Okay. Doesn't fully get better. And maybe the other thing to mention, this is a little harder to do in bed, if you have a soft mattress and things, but taking like a massage ball, and just putting it under your glutes and kind of doing like a self-release kind of massage on them. We'll do it on the ground, like a little firmer surface, and you can kind of sit and then you lean to the side and you put that ball right in that kind of glute, that meaty glute area. Yeah. And you can just roll around in there and you'll find tender spots, and that can be a good way to, it's amazing how like just a tennis ball, how much you can release with that.
Right. So what about massage? So if you had, let's just say that you did 3 weeks of massage, will that kind of solve the issue long term, or does that only solve it?
It's so variable. Like some people, some soft tissue work a few times will their symptoms will totally go away.
Right.
And then you get other people where they just have these bouts of just like they're prone to chronic tightness, that feeling of tightness in an area. And it's almost like you get some people where they just have a stretching program that they have to implement at a certain basis, and they just learn that over time that they need to incorporate that to manage their symptoms and kind of keep them. People are so unique in terms of their symptoms. Like you might have a bunch of different people that come in and complain of glute tightness, but the way forward that works for each person can be totally different. Wow. Yeah. I mean, it usually the nice thing is it usually does revolve around kind of the same interventions, but it's sort of like the dosage of those interventions, like how often they're doing them, what specific types of stretches or mobilizations, or massage therapy. I mean, even sometimes glute tightness like that, there might be, you get some people where like they feel like acupuncture and an intervention like that really helps them. So
interesting.
I always tell people, I think you have to kind of think of yourself, your pain and symptoms and tightness is totally unique to you, and you have to think of yourself almost as an experiment and test different things and just see what works best for your situation. But I think for most people who have a tightness like that, starting with stretching and kind of self-massage techniques with a ball or a foam roller are the best places to start.
Okay. Okay, so the next one, and I'm gonna butcher some names because I'm not speech pathologist or whatever you need to be to get people's names right. But it's Isa Van Stralen. I'm gonna go with that. And she's got pain in anterior of both knees with movement in a wave afterwards. What should she do?
Okay, so anterior knee is basically the front of the knee.
Okay.
And we've talked about this in one other episode. There's two things that, there can be a bunch of things that hurt people on the front of the knee, but the two most common are the joint behind the kneecap, the patellofemoral joint. So you can't touch that, but it's literally a joint on the back side of your kneecap.
Is this what I had when I was talking about sitting?
You had the other one, which was, I think before when you were asking about it, it was after you played basketball, and I think we were thinking it was more your patellar tendon,
Okay.
which is the other anterior knee thing that can hurt people.
Okay,
So,
sorry.
Yeah, no, that's good, because
Yeah.
it's the two most common. So the patellofemoral pain would be, like I said, would be behind the kneecap, and that one would tend to be aggravated with things that put pressure on the kneecap. So it could be like the sitting, like you were talking about, if you're sitting with your knee bent for long periods. Or things like squats, lunges, going up and down stairs. Those all put your quadricep muscles on the front of your thigh are contracting, and then that compresses the patellofemoral joint. And then the other one is the patellar tendon, which also, because the patellar tendon hooks to your quads, it's also aggravated with quadricep exercises. So you see that more in jumping athletes like volleyball, basketball, and it will hurt kind of down below the kneecap. Usually kind of down below the kneecap, in that you can feel the tendon on the front of the knee.
Yeah. Is it a repetitive? Like
Yes.
they're just jumping over
Yes,
and over?
totally.
Okay.
Yeah, that one, they're actually kind of both tend to be categorized as kind of that repetitive. Usually you're doing the people are doing a certain volume of something. Like if it's patellofemoral joint, maybe I just had a lady recently who had just moved into a house where there was more stairs than normal.
Okay.
And in her case, it was her patellofemoral joint. There's a test sometimes we do in physical therapy where the person's sitting with their leg out straight, and it's not a very fun test. It's called a scour, but you basically push the person's kneecap down and kind of grind it, and you look to see if it reproduces their symptoms.
Okay.
You're basically loading the backside of the patellofemoral joint where that cartilage and that joint is, and if that creates their pain, then it can be a positive test for patellofemoral symptoms. The patellar tendon's a little easier. You can just get down there and kind of palpate it and kind of rub your finger on it, and you can usually find spots that, if they have a patellar tendon irritation, that brings it on. So it's a little tricky with this person's asking about anterior knee pain when they do movement. We don't know what movement, but and they get waves of pain that come on after.
Yeah.
So, I think as a general rule of thumb, maybe something that's good for people to keep in mind is that in rehab, we're okay. It's easy for me to say I don't have the pain, but we're generally okay with people having mild to moderate discomfort during an exercise and maybe for a few hours after. What we don't want to see is that by the next day, their baseline pain is worse.
Okay.
So say they came into physical therapy and they said, you asked them during your kind of intake, what's your pain right now? And they say, oh, my knee pain, on average, is around a 3 out of 10.
Right.
And then you do the exercises and say they do certain exercises to challenge the area, mobility, strength exercises, and say they get up to a 4 or 5 out of 10. And then their knee feels a little aggravated for a few hours after. But then by the next day, they're back to
the 3
out of 10. Then it's like, okay, that was probably an okay amount. But if they say the next morning, I've been at a 5 out of 10 and it's just been flared up, then you've got to probably back off on what you did. It might mean doing less reps, less sets. Maybe it was too many exercises. Maybe the exercise you picked was too stressful for their current state. This is where there's so much nuance in exercise prescription. You could have one exercise and prescribe it totally different for different people.
Okay.
So I think that individual, if they're having waves of pain after movement, if that only lasts for a few hours and by the next day they're kind of back to baseline, I'd say it's probably okay. But if it's worse still the next day, then I think they have to look at what they did that previous day and maybe write it down, really get detailed with it. What movements did I do? How many sets and reps of those did I do? And then how can I maybe dial it back a little bit to meet my body where it's at right now?
Okay. So this doesn't have to be a permanent forever thing.
No.
Right.
Yeah, no. Yeah, it's just allowing you're basically just trying to give your body time to adapt.
Okay.
I mean, and even someone else just asked me about this, someone who has patellofemoral pain, and I had sent him some exercises, and they were just continuing to aggravate him. And they were some exercises that were a little bit more knee focused, and I think his body just wasn't quite ready for it. And so, one thing, we could, of course, just kind of dial back how many of those exercises he was doing, the sets and reps on them. Or, somebody has a really flared up knee, there's actually a lot of research for glute strengthening.
Okay.
So sometimes if somebody's really flared up, we'll just start them with glute strengthening. Okay. And then as their knee calms down, then we slowly start putting more stress on the knee.
Right. It's amazing how everything's so codependent. Right?
Oh, yeah. It's that whole kinetic chain. Yeah. Like your glutes are so important in knee health because you think about your glutes attached to your femur, which is your upper thigh bone, and that femur bone is half of your knee joint.
Right.
So your glutes have really kind of this direct impact on your knee joint. Mm-hmm.
So the issue that I had, I think I did it playing basketball with my son.
Yep.
And anytime my knee would be at 90 degrees, I would have pain, pretty quickly. So sitting on a plane, but as soon as I stretched my leg out, totally fine, kind of thing. And you told me that it's a time thing. It just takes some time, and you were 100% right. Like I didn't really do anything, but I probably took longer than I needed to recover because I didn't do anything. What would you suggest would have sped that up?
Yeah, it is kind of funny how these things work out. There's actually quite a bit of studies out there on different musculoskeletal conditions, and it's this exact concept you're talking about where most things, I think it's reassuring to people, most conditions just get better with time.
Right.
The practitioners sometimes will take credit. I think take more credit than they should. Like if somebody's getting better.
Mine took like 6 months.
It did.
Because I didn't do anything.
Yeah.
Right.
A lot of conditions are like that. There's a lot of connective tissue conditions, like tendon conditions, that if you just track them, it's usually somewhere in like that 6 to 8 month time frame. They just kind of get better.
Okay.
So the question is, I guess that is your hope in rehab, is that you're speeding that process up for someone. I mean, I think probably even more than that, the rehab exercises help reduce the likelihood that it comes back.
Right.
Because even though things will desensitize in most cases and get better with time, if you didn't really do anything for it, it's not like you probably didn't add strengthening exercises or things to build up, the integrity and capacity of the tendon. So if you were to go play basketball again, it's probably likely it would come back.
Right. So I what I'd want to do is I'd want to build up some stuff.
For sure. Yeah. If like if you say you guys were going to start playing basketball more regularly.
Which I should.
Definitely. Oh, yeah. Like just even, just from the exercise standpoint side of it, just like to get out there. I know you've been thinking about like things getting back into in terms of exercise.
Yeah.
I would say that would be, if that was something on your list of items, like an activity you'd be interested in, it'd be huge to leading up to that for maybe 4 to 8 weeks to have kind of a program where you just look at adding in kind of slow, heavy strengthening exercises for your lower body. Yeah. And really targeting those tissues that would be stressed in basketball. Yeah. Because so many of these connective tissue tendon problems, their pain goes away when they're resting, but then as soon as they return to the activity that triggered the pain, it just comes back again. Yeah. You hear this so often. And unfortunately, a lot of doctors will tell people, just not to bash on doctors, there's a lot that say, of course, have great recommendations, but all too often I'll have people say, my doctor told me just to rest. Right. And the pain will go away, but as soon as you go back to anything that stresses the tendon, the pain tends to just come back.
You're not addressing the underlying condition. And I think with me, you don't want to not play basketball because it's good for you and to be active and stuff like that. So one little side note on that too is I have a good friend that's an orthopedic surgeon in Atlanta. He's brilliant. And I phoned him up and I said, hey, this is what's happening. What do you think's going on? He goes, one word, arthritis.
Oh, man.
That's it. And then I talked to Tom, and Tom gave me the perfect diagnosis I don't even think you had to touch it. You just, I told you asked the right questions.
Yeah. Just based on kind of your symptoms and.
Yeah. And you were 100% right. So yeah, that was cool.
That's so sad to hear, actually, because you can have some surgeons that are amazing surgeons, but, I think sometimes surgeons don't think about the power of the language and what you say to people, like the words you're choosing to use. Just throwing a diagnosis like arthritis out to someone without any kind of testing, no imaging, just that can really be harmful to people. Yeah. Like it can freak people out. They're like, oh crap, I have arthritis. Like I'm doomed.
I thought that was it. And okay, well, I can't play basketball anymore. I can shoot, but I'm not going to run with the kids and stuff.
Yeah.
And so anyways, it's all very interesting, especially how right you were, like just bang on right. So
yeah, well, That's awesome that it got. But most things, I think that that's one of the things I'm telling people so often is that most conditions will just get better with time. Like,
Right.
and hopefully the rehab exercises will kind of speed that process up. And then I think probably the big part is that the condition is less likely to come back. That's the main part of rehab in a lot of ways. It's like, well, a big part of it is making sure you don't have some lasting impairment, like we were talking about before, like you don't lose mobility or that's really in a lot of cases is the big one, making sure people don't develop some kind of joint contracture and permanently lose mobility. But the other side of it is just getting people stronger so that they're less likely to have that problem come back again.
Right.
So
okay. Can you do? I'm thinking maybe one more question.
Yeah, that's perfect.
And then we have
do another
more questions. But
yeah,
we'll do another episode.
Yes, do a whole nother episode. I like these Q&As, and we had about 9 questions this first go
we
around.
have 9 questions.
Yeah. So if you didn't hear your question, you had one, we'll get to it on the next episode. But yeah, let's do one more.
Okay, so one more. So this is from, again, I'm not a speech person, but Midjem Madalan. Midjem, I'm not saying it right, and I'm sorry. So the question is, can a slap tear be repaired, which I don't know what a slap tear is, without surgery? If so, how? And thank you.
Yeah, so a slap tear is a labral tear in the shoulder.
Okay.
So it's in the top of the labrum. So SLAP stands for superior labrum, anterior to posterior. So it's the labrum. You have one in your hip and your shoulder. It's a piece of fibrocartilage that forms a rim. So if you think about your shoulder socket, it goes around the shoulder socket. It basically makes the socket deeper, makes it more like a cup, so that the ball and socket joint is less likely to slip out.
Okay.
But if you there are different types of labral tears. Slap tears you hear about quite a bit, and a lot of times with slap tears, people will feel pain on the front of their shoulder, and there's some research showing that people with slap tears can go undiagnosed for around like 2 years or more.
Wow.
Because it's often diagnosed as, you just have a biceps tendinopathy, or maybe it's a rotator cuff related pain, something like that. So if you have had pain on the front of your shoulder for a long time and it hasn't gotten better things, sometimes having an MRI just to make sure there's not a labral tear can be good. The thing about the labrum is that it doesn't heal very well. So if you went and had an MRI and you saw a labral tear, the other one is called a Bankart. There's a Bankart lesion. Those are the two you hear about quite a bit. If you saw the tear like that on MRI and then you went through rehab and your pain got better and your strength and function, all that improved, you could do another MRI and probably still see it there. So this is another one of those examples where we're trying to get people to understand that even though that tissue might not heal, your pain and function can improve, and you likely would, in a lot of cases, never need surgery.
Okay.
So this is another one that comes up quite a bit. I was just having a conversation with somebody about this the other day. They have a slap tear as a bodybuilder and wanted to know if he should have surgery. And so one of my questions initially with these types of labral tears in the shoulder is your shoulder dislocating frequently? Like, is it popping out of the socket? And so if your shoulder's popping out of the socket all the time, then you're really a candidate for surgery. Because people who've had multiple shoulder dislocations, their success rate with rehab is much lower. So there are some studies saying it's only about 15%.
Oh, wow. Really?
So it is way more likely. I had a buddy, actually, one of my classmates at physical therapy school. His shoulder was so loose that if he wasn't really conscious of what he was doing, like say he was waking up and kind of out of it, to hit his alarm clock, his shoulder would dislocate.
Wow, really?
So he had dislocated multiple times, and it just, those passive kind of restraints, the labrum, the joint capsule, the ligaments, they had been so stretched out that he just couldn't keep it in the socket, very well. And so someone like that is a good candidate for surgery. This bodybuilder I was talking to, he had never had a shoulder dislocation, but he had a labral tear. So he just had pain. And if you are someone who you haven't had lots of joint dislocations, you just have pain, definitely try to go the rehab route as long as you can.
Right.
It's like we were just talking about, some conditions take a long time to get better.
Right.
So to me, a labral tear is one of those ones where you'd want to give it at least a year. If you only have pain and your joint's not dislocating, give it a year of rehab and just time, and then make a decision.
Right.
But and if at that point you still have a lot of pain and it's really interfering with your function, then maybe you talk to a surgeon about having surgery. But it could also be like experimenting with PRP. We were talking to Dr. Yao about PRP, and those interventions, like the research is kind of mixed. But I think if it were me and I were in that situation, I had a labral tear and I just had pain and I was doing all the rehab consistently and I still wasn't getting the results I wanted, that's where I think, maybe I'd explore a non-invasive or less invasive intervention like an injection versus jumping into surgery.
Okay.
I have a labral tear in my hip, my left hip,
Okay.
and I have had it for 10 years, and I just have figured out how to manage it. I know certain things that flared up, and I just don't feel like it's worth the risk of having surgery when I can just kind of manage it and work around it. The shoulder's a little trickier because the shoulder's a more naturally unstable joint.
Right.
So you just really have to look at it. Does my joint dislocate a lot? Then I'm probably more of a surgical candidate. If it's just pain, then I think try to avoid surgery and just go through rehab.
So, little side note: the shoulder when somebody when their shoulder joint or pops out or whatever, if it happens once, does it make it that it's going to keep happening, or is it sometimes it doesn't screw everything up, I guess?
Yeah, if you only have a one-time dislocation, your chances of getting better with rehab and not having a future one is a lot higher. It's really once people get in, I mean, your risk is higher. Like if you dislocated once, you've probably stretched out some of those static stabilizers, and so your risk is higher of having a second dislocation. But there are a lot of people that if they've only had one dislocation, we really tell them like make rehab your primary focus in terms of getting better. Don't jump into surgery right away after one. But if you get to where you've had like 2-3 dislocations, then it's pretty stretched out and it's going to be harder to manage with just strengthening exercises.
Okay.
But first time, one-time dislocation, focus on rehab.
Okay. Perfect.
Okay, sweet. Well, that's we got a few questions in. We got 5 questions. So I hope this is helpful to everyone. We've got a few more. If I didn't get yours answered today, we'll put that in another episode. And if you guys like these Q&A episodes, we'll plan to do more of them. And again, I can put questions out on my Instagram and take in some of those questions that might be relevant to lots of people. These were great ones, things like labral tears, what else? Knee pain. Like we had a bunch of good ones. Tendon, patellar tendon. We had a couple of knee ones. Like a lot of good ones that, in terms of when I'm posting content, these are topics that come up a lot. So they're great questions to have on the podcast. So hope this was helpful, everyone, and we'll see you in the next episode. Thanks, Ben.
Thank you. It was great. Thank you.